We're a little bit behind, but I think our time has been very well spent. I think Eric Dishman gave us a pretty phenomenal launch into some thinking in that gap between practical thinking and possibility thinking. We're going to move forward now with this session on technology and with the question of what will it take to get to the ideal state. So I think just in the interest of time, we're going to begin right away with our first speaker, and again with brief introductions. So very pleased to have George Demiris from University of Washington. George.
Thank you. I'm honored to be here, and I'm going to be talking to you today about the evidence base for the use of home health technologies, and hopefully give you some overview of what the scientific literature shows in terms of what works and what doesn't work, and then also some lessons learned basically based on that literature review, as well as some of our own projects and experience. So we already know that information technology is affecting home healthcare. Technology advances, and now computing is pervasive and ubiquitous. It's wearable. It's basically in every aspect of our life. And so we hope that information technology can actually be used to improve the quality of services in home care, and in some cases perhaps help us redesign those services. IT has been used for a long time now to bridge geographic distance with telemedicine and telehealth applications, and hopefully to increase access to information for patients and their families, allow people to access expert opinions without having to travel. And clearly this is an area that continues to grow. In 2003, if you searched for papers that were published that year and were indexed in Medline, you would see 556 articles. In 2013, the number of publications that were published that had the technology and home health focus were 1,390. That's just as an example of how the field continues to grow, and at the same time, the initiatives and the studies and the evidence that goes with that continue to grow as well. We are talking about technologies in general. One possible distinction that's often used is to distinguish between active and passive technologies. Active technologies being the ones that somebody has to operate, whether it's a piece of hardware or software that somebody has to learn to use, or perhaps it's intuitive and you can use it without having to undergo training, or your family can use, or it's something that you wear and operate, versus passive technologies, and we've seen some earlier today, that are embedded in the residential infrastructure and basically allow for monitoring of people without them having to operate anything. That would be the case with smart homes or digitally augmented residences, where you have sensors or other types of technologies that become part of the residential infrastructure. And when you see those technologies in the literature, they have clearly a variety of functionalities. So I'm going through some examples, distinguishing between active and passive monitoring, and describing those types of functionalities that technologies may have. So one big area is physiological monitoring. And in active monitoring, you are probably familiar with home telehealth, the solutions that allow you to capture vital signs, weight, or report other symptoms, and transmit that data to a remote provider or to a home care agency. And similarly, in physiological monitoring, you do see some passive monitoring applications, such as bed sensors that you put under the bed sheet, and those capture restlessness or sleep interruptions, pulse, and respiration. Another type of functionality for those technologies is functional monitoring or emergency detection and response. One example of an active monitoring technology would be a fall detection device that one would wear, or a personal emergency response system. That's something that people wear and they press a button when they have fallen. And in the passive monitoring space, you see similar technologies that are perhaps embedded in the carpet, such as gait monitoring that detects falls or near falls. Another functionality is safety monitoring and assistance. Again, in the active monitoring space, we see a lot of alert systems that will detect some type of emergency and allow somebody to connect to family or 911 or to healthcare specialists. And similarly, with passive monitoring, you can have sensors that would detect those emergencies and notify for you somebody who needs to respond, such as stove sensors, where you can, based on a combination of motion sensors and heat sensors, distinguish between meal preparation versus somebody having turned on the stove and left. In security monitoring and assistance, we have technologies that allow for active monitoring of one's residence. You can use webcams or other types of applications that allow you to monitor what is happening in your home or in the home of your loved one. And similarly, with passive monitoring, you can have sensors that are throughout the home, such as motion sensors, that will alert when there is an unusual pattern, let's say no motion for a certain number of hours, or somebody has intruded. There's also the functionality of social interaction monitoring and assistance. And for that, we know that there's a lot of different social network applications that will allow people to connect to peers, people with the same diagnosis, or people who are in the same geographic region or in further away regions, and people can connect in those virtual communities. And similarly, you can assess social interactions through passive monitoring, for example, with sensors that will let you know how much time was spent inside the home versus outside the home, or the number of visitors that somebody may have. And finally, the last category would be cognitive and sensory assistance. Those would be technologies that help with cognitive limitations, that provide reminders and cues, or that help you process complex tasks. An active monitoring technology would be, for example, medication dispensing devices that allow you to manage complex medication by having those be automatically dispensed at pre-programmed times. And a passive monitoring solution would be, for example, when the lights go on at night as soon as you wake up because of sensor mats that detect that somebody has woken, and so the lights go on, let's say in the bathroom, so that it allows somebody to walk and move around at night without the fear of falling. So I'm talking today about the evidence base. Obviously, as I mentioned, we have a growing number of scientific articles that look at the use of technology in home care. And we have clearly moved more from the early pilot or feasibility studies with very small sample sizes to ones that are actually now more extensive, some cases longitudinal, and clearly we see many more randomized clinical trials than we used to 10 years ago. And while the evidence is growing, it's still not really clear what seems to work and what doesn't work. At times we have contradicting findings. For example, I've listed two studies here from the same year. The Stevenson study from 2012 that was done in the UK that showed that home telemonitoring decreased mortality rates for people with chronic conditions. And the Takahashi study in Minnesota that also in a randomized clinical trial showed unexpectedly that telemonitoring increased mortality for the intervention group. And although the reasons could have to do with study design and selection bias and so forth, this is the kind of example where if one were to decide what technology to utilize and for what purpose, sometimes the evidence out there is not 100% clear. Technology grows, and those developments are often more rapid than the traditional research grant cycles for a researcher. So in many cases, by the time you've conceptualized the study and have acquired the funding to carry it out, that technology may be redundant. And you'll see many examples where NIH-funded studies used PDAs or other portable units right before the iPhone came out that really changed the way we perceive our phones. But you are often stuck with an outdated technology in a randomized clinical trial. And in some cases in research, you can't really tailor the technologies based on the infrastructure of the home or the needs of the individual patients because you want everybody to be exposed to the same intervention. And that, again, can create lots of challenges. By sharing some lessons learned, I wanted to first point out that when we talk about technology, it doesn't always have to be a very complex, high-tech, sophisticated solution, and that sometimes simple technology tools can be effective. We've done some work in our hospice caregiving research network where we looked at ways to support hospice caregivers, and those are the informal caregivers, the family members, friends, spouses, or others. And what we've done in this clinical trial is try and deliver a problem-solving therapy intervention to those caregivers, recognizing that problem-solving therapy has been found effective for many caregivers in different groups, but it's obviously costly to add visits for that purpose. We've been looking at using just regular video conferencing, similar to Skype, or video phones for those who do not have a computer, to actually deliver that intervention via video. So we have a 3-arm clinical trial with an attention control group that receives friendly visits and usual care, an intervention group that receives the same plus, receives standard care plus the problem-solving therapy in person, and one that receives the intervention via video, with a goal to see if those two modalities are equivalent, in which case it could be cost-saving. And we have now over 500 people recruited. We have 3 more months of data collection. And while we haven't analyzed the data yet for the final findings, I can tell you that people are embracing the technology and are finding it to be a convenient and effective way to communicate with interventionists. Using similar technology, and again in hospice, we use the video to bring the caregivers as virtual team meetings in interdisciplinary team meetings. So hospice agencies are federally mandated to have IDT meetings at least every 2 weeks. And theoretically, the patient and the caregiver are invited to attend those. But of course, given geographic distance, the patient's frailty, and the fact that each case maybe gets discussed for 5 minutes, nobody really attends. So in this clinical trial, we brought the caregivers with the use of video into the team meeting, where they got to see some of the important stakeholders, like the medical director, for the first time. And the intervention focused around pain management, because we identified that caregivers were raising the concern around pain management and concerns they had around that, which in some cases was never shared with the hospice team. So there's a protocol by which they get to use their 5 minutes to talk about any concerns or fears they have, as well as ask questions and get the team to acknowledge and receive those concerns. Again, this is an example of a very low cost and simple technology. Sometimes we have technologies that allow us to just capture what we've always been capturing in a more effective or efficient way. And sometimes with new and emerging technologies, we can capture new things. So while in traditional telehome care, we now can have people capture their own blood pressure or their own weight rather than wait for the nurse visit to have those captured. With some of the new technologies, we now get information about lifestyle or behavior in the home that before we had to rely on self-reporting. This is a study we're conducting that's funded by NSF that's looking at smart home technologies for community dwelling older adults. And we're looking at people who live in retirement communities and are using various sensors, including stove sensors, motion sensors, and 2 sensors developed by engineers at the University of Washington, one that allows you to detect water consumption and also identify the source, and similarly one that allows you to identify electricity consumption and identify the source, and use that information to assess overall mobility of people in the home. So we've installed different sensors throughout the home, hopefully in a not too intrusive kind of way. And we're gathering data about the sensor firings. And what I mean by new data is that now we have information about sleep quality, or at least sleep interruptions, bathroom visits, restlessness at night, sedentary behavior, hygiene patterns, meal preparations. And it's information that you no longer have to rely on self-reporting or having people recall details about their activities for the last week or 2 weeks. The challenge there is obviously not to just process the data for the sake of having the data, but rather have some sophisticated algorithms that would detect patterns and deviations from what would be considered the norm for each participant. So hopefully you wouldn't actually burden healthcare providers with the day-to-day or second-to-second information from sensor firings, but rather show a trajectory where perhaps immediate attention may be required. Another point that's very important to think about when discussing technology is the issue of usability, or more broadly, the design of interface, whether this is hardware or software. And a lot of the monitoring device companies have actually failed to include older adults in their testing for usability. And it is disheartening to see that many of the software apps too describe in their testing sessions participants being between 20 to 25-year-olds. I've used here an example of a study we conducted with a telehealth kiosk in a community where people were asked to come and assess their vital signs and also do some cognitive training and respond to questions. And it was a multi-user kiosk. And what we found, given that it was a multi-user kiosk, was that you have to continuously tailor the technology to address functional or visual or cognitive limitations that people may have, inexperience with computers, visual impairment, and that not everybody has the same challenges, so you have to create technology that's flexible enough to accommodate for all those different limitations. And similarly, when it comes to visualizing the data, this is an example of the personal wellness record that this kiosk provides. It's very challenging to create a kind of interface that would be user-friendly and make sense to the different stakeholders. So clearly, as you can imagine, by conducting focus groups, we found that a lot of our older adults had very different visualization needs from their family members and obviously from their clinicians, not only in the type of information and the level of detail that they wanted displayed, but also when it came to the use of colors or pop-up features or things that one group may find distracting versus another group that may find useful. And then the final point I wanted to make was the challenge we have when we talk about technologies, which is to understand and study acceptance. A lot of studies report high levels of satisfaction because they survey users of a certain system if they're satisfied, and people respond yes. So you'll see that in many cases we have high levels of satisfaction. But when you actually think about the concerns that people may have about technologies in their home, it is a much more complex concept than that. We've looked at the concept of obtrusiveness because many times people say, well, in passive monitoring, you don't have to have users operate anything, so they're non-obtrusive. But obtrusiveness is much broader, and it does really capture the user experience, their subjective assessment of whether technology has undesirable features that may be psychologically or physically prominent. So we've looked at the framework of obtrusiveness to try and capture all those different dimensions that obtrusiveness may have. Clearly, privacy is a huge issue, but it's not the only one. There's other dimensions that really pertain to challenges that people may experience when they have technology installed in their home. It's the physical aspects of where the technology goes, and several of our participants in smart home projects talk about the technology not ruining their wallpaper or not being too visible. It's the issue of usability that I already mentioned. The challenge of privacy, which is not only around what happens to the data, but also people's perceptions about what may happen to their data. The issue of function, how the equipment works. There are studies where people complain about loud noises that come from monitoring units or that they need a lot of maintenance. There's the concern that people have about the role of technology on human interaction and whether those would actually reduce actual face-to-face visits. There's the issue of self-concept and the potential stigma that you may identify when you have technology in your home, or as some people call it, turning the home into an ICU unit. There's the issue of how the technology may affect people's daily routines and rituals, and ultimately the concern on how this can be sustainable. And in many research studies, you will see people saying, I really appreciate this technology, but I'm not sure I could pay out of pocket if it was not a research project, or who would be paying for this if this was not funded as part of a research initiative. So in summary, I think while we see a lot of potential in the technology, and now we have more evidence that technology can actually improve the quality of services in home care, it's really about finding technology as a tool to meet clinical needs rather than have the technology be viewed as a solution to any of the problems we're facing. And with that, I want to thank you for your attention.
Thank you. Now we're going to have Raj Koshal, as Chief Clinical Officer from Almost Home.